Okay, so let's talk about atelectasis. So let's talk about the patho of atelectasis. And how does that happen? What happens and who do we see it in? Y'all put any of that in?
Well, over here we put history of recent surgery.
Okay, so recent surgery. So that's a cause. What's another cause?
Other respiratory disorders.
Okay, so that's good. Other respiratory disorders. So what other respiratory disorders?
Like pneumonia.
Okay, so pneumonia could cause it, yeah. Okay, what else? What about COPD? COPD, emphysema, okay? Okay, so we can see atelectasis. Atelectasis is a result. It's not really a disease in and of itself. It's a result of something going on within the respiratory system. So where do we see atelectasis? Where is it going to present itself within the respiratory system? So the alveoli, okay? So we're going to see it in the alveoli. So what happens to the alveoli? It's important to know this. I don't really usually get onto the patho a whole lot, but for the atelectasis, it's important to know this and that it's a result of some of these other disease processes. Okay, so they collapse. So if the alveoli are collapsed, what will we see?
Impaired gas exchange.
Okay, so impaired gas exchange, is that up here? So we see impaired gas exchange. Okay, so when we have impaired gas exchange, when we start getting into these lower respiratory, I get excited because I like talking about these lower respiratory disorders. So, okay, so when we have impaired gas exchange, we've got, and I'm going to tell you all on those, Tiffany, you could leave that open a little bit so you can get back in. Does anybody need a break? I didn't even ask y'all that. I get to go when. Okay, let me finish this and we'll take a quick break, okay? So, and if you need to get up and go ahead. That's fine. So what happens here? I'm not horribly concerned with you all knowing the oxyhemoglobin dissociation curve that your book describes. Okay?
That's a good thing.
Okay,
I like
that is a mouthful. So, I want you all to have an understanding of what happens. So we breathe air in, it goes in, it's humidified, it goes all the way down through the system. We exchange it at that cellular level in the alveoli, and we breathe out. It's exchanged with CO2. The CO2 comes out. We breathe it out. Okay. Y'all know the basis of respiration, ventilation, and gas exchange. Okay. If something is wrong with those alveoli, we're not going to have gas exchange the way that we should. So with atelectasis, there's something wrong with the alveoli. There's not enough surface area there, so we're not getting the gas exchange that we should. So our manifestations and within our assessment is what we're going to see with atelectasis, okay? Now, depending on the degree of the disease, depends on what we will see, okay? So we can see decreased breath sounds. You all cover just about every one of them. Decreased breath sounds. So in the worst case scenario, what would be the first thing that you would see with atelectasis? One of the first things. Probably not. Probably not. It's probably going to be difficulty in breathing. Dyspnea. Okay? So on the very bottom. So dyspnea. So that may be one of the first things that you see with atelectasis. Now, in some of these disease processes like COPD, this is going to be a progressive disease, okay? if it's something like pneumonia over here, it may not be, it may be something that is acute, and it may be dyspnea is the presenting sign and symptom. Okay,
Can I have hypoxia?
they can have hypoxia, but it depends on the disease process. Okay, so you can't just say everybody with atelectasis that their first sign and symptom is going to be hypoxia, because it could be hypoxia with some, and it may not be with others. Okay, so you just have to know like what is going on with that patient. You know what? That's why I said it's good to know what's pneumonia, what is COPD, what is what is asthma. Okay, so if they're not exchanging gas the way that they should, all of these things, decrease in breath sounds, especially in those lower lobes, you're going to have decreased breath sounds. They may be cyanotic, but this is probably a late sign and symptom. Okay, hopefully they're on some oxygen. They may have a cough, but it may be productive. It may not be, depending on the disease process. Okay, so it could be productive versus non-productive. Okay, they may be diaphoretic and a decreased heart rate. A history of smoking can cause atelectasis, so that's an important one right there. And when we're talking about a lot of these diseases, we're talking about smoking cessation. So diagnostic, ABGs is a good place to start, because we need to know what their gas exchange is, okay, and are they poorly exchanging gas, and just a basic SAT. One of my friends is an anesthesia provider, and he told me the other day, he said, you know what, if I could get it through to the PACU nurses that the most important thing to put on a patient is a pulse oximetry, my job would be so much easier. He said, because that's going to give me what their oxygen saturation is, and what their waveform is, what their respiratory rate is, and if they're tachycardic or not. He said, it's giving me a lot of things right there. Yes.
Will we learn anything about waveforms at some point? No. Okay.
You might later on, but basically, if they've got a good consistent waveform on that peak in the SaO2, then that's a good indicator that it's on there and they're perfusing. Okay. If it's not, then if you've got just a small little bump, then that may mean that they're not perfusing well. Okay. So ABGs and chest X-ray. So the chest X-ray may show consolidation. Okay. The ABGs, that may be a varying degree. Okay. It depends on the disease process. So I'm not going to say it's respiratory alkalosis, it's respiratory acidosis. It's going to depend on which one of the disease processes that they are going through. Okay.
Describe what consolidation is.
Consolidation means that normally the alveoli are filled with air, and there's no surface tension, there's no surface area there, and everything looks like it's like solid in there. It looks solid. So like if you are looking at pneumonia on a chest X-ray, you'll see areas of consolidation where there's mucus or there's infection. It could be lobular consolidation, so the entire lobe may look darkened and you may not even be able to see anything. The lungs are usually air-filled, so they show up translucent on an X-ray, but they're showing dark, which looks like consolidation. So where you usually can see through it, you pour some Coke in there, you can't see. If you had a glass of water and then you could see through it, you pour Coke in there, you can't see through it. Okay. I have stupid analogies.
Now I like that. I like the stupid.
A bronchoscopy and a CT are going to be good diagnostics, because you can get down in there and look at those airways, okay, with the bronchoscopy. Meds. If they have an infection going on that's causing the atelectasis, then yes, antibiotics are important. Okay, antibiotics are real important. Bronchodilators are your biggest thing there, because you want to open up those airways. Okay, And there's a lot of things that you can do. Deep breathing exercise. I like all of their interventions here. And Kelly's really going to like this one because you wrote up here respiratory. Collaborate with respiratory. And pain relievers if they're having some pain. But we want to be careful with pain relievers because they're already having trouble breathing. We don't want to knock out their respiratory drive. So we want to make sure that we're careful with that. Interventions. Okay, so deep breathing. Your book talks a lot in a lot of different places about breathing retraining, which is basically focusing the patient on how they're breathing. People who have chronic lung disease, they tend to breathe up here. You know, we've got that overinflation of the chest. They tend to breathe from the top, and we need to teach them how to do diaphragmatic breathing. So to retrain them to breathe from the diaphragm will help to open up those alveoli and help to get that airflow back in, okay? So we want to teach them breathing, deep breathing exercises and coughing, okay? If they're having atelectasis from mucus production and mucus that is in there, then they need to be coughing and they need to be deep breathing. And your book also, I think it's in COPD or asthma, I think it's in COPD, it talks about having them to focus on how that they cough, okay? So if you're focusing on how that you cough, you're coughing deep. So you want to take a good deep breath and cough like that instead of a hacky cough, okay? So you want the patient to focus on how that they're breathing, okay? So as the nurse, you may have to collaborate with respiratory therapy on how that they're coughing and deep breathing, okay? And that breathing retraining. So respiratory therapy can teach them how to breathe, do breathing retraining, but we can reinforce that, okay? Ambulation and positioning. So do these folks who have atelectasis need to be supine? Okay, so what position are we going to put them in? Semi to high Fowlers. That's going to be priority because we don't want them, they're going to feel like that they, you know, are not able to get a breath at all if we don't put them in the Fowlers position, some sort of Fowlers. Collaborate with respiratory therapy. This is really important. Respiratory therapy can, you know, they probably are going to have nebs ordered that will help open those airways up. So respiratory, they may have them ordered so often and then they may have them ordered on a PRN basis. So if the patient is having trouble breathing and they haven't had a neb in a while, then they may need to have respiratory therapy called to get that neb. This is one of the simplest things that we can do for an intervention, and that helps with breathing retraining. Okay, so this and this work hand in hand together. Incentive spirometry. Your book goes into all kinds of things about incentive spirometry, and I have an incentive spirometry up there. I have one at home, I think. I couldn't find it, so I'm not going to demonstrate on that one. I was going to demonstrate on mine, but I can't because I don't know who's had their mouth on that one. But basically, the patient, you set a goal for the patient, and then they work on that every hour. You know, you encourage them every time you're in the room. Have you been using their incentive? And then you have them to do that in front of you to make sure they're doing it right. Because if they're just going, they're not taking good deep breaths. That needs to be a good, and they're not blowing into it. They're wanting to pull the air out and raise that meter up and see how far that they can go, okay? It's not really about how long that they can hold it, because they may not be able to hold it real long, okay? If they needed oxygen, we want to monitor their vital signs and breath sounds. So we didn't talk about breath sounds over here so much, but what would we have decreased. Okay, there it is. Decreased breath sounds. So they may be diminished, they may have wheezes, and they may have some crackles. They may have all kinds of stuff going on, okay? But they may really have decreased or diminished breath sounds. So we want to see, are those breath sounds improving, right? Because of our interventions, because of what interventions that we have done right here. We want to see, are they improving? Are their vital signs getting better? Are their ABGs returning back to better to what is normal for them, okay? So either they're in for acute pneumonia and maybe they have atelectasis from that, and is it returning to what it should be, or is it a baseline, okay? And activity tolerance. So what are you going to evaluate with activity tolerance?
Not be still becoming short of breath.
Okay, if they're becoming short of breath with ambulation, if they're becoming short of breath with just activities of daily living, you know, and we need to, as the nurse, if they're ambulating, we need to ensure that we're documenting how far that they're ambulating so that we can assess, are they getting better and are they able to walk further, or are they getting worse, okay? All right, so let's take a quick break because Kelly's going to be up here in about 20 minutes. So y'all take a quick break and we'll get started back, okay?